Good afternoon, everyone. I'm Kelly Boyd with WLBT, and this is Ask the Experts. Joining me in the hub today is Dr. Bellan from Baptist Heart. Hi, Dr. Bellan.
Hello.
Welcome.
Nice to be here.
Thank you for joining us. Yes.
Glad to do it.
Would you like to tell everyone about your specialty as you're a cardiologist, right?
Yes,
Okay.
yes. I practice general cardiology, so anything in any sense related to the heart and
Matters of the heart.
circulation. And I trained an additional year specifically in interventional cardiology, which is the treatment of narrowed or blocked arteries through catheters, minimally invasive procedures on the heart.
Okay. Dr. Bellan's going to answer the questions that were submitted to our Ask the Experts page on WLBT.com, but you are welcome to join the conversation while you're live. Ask the questions that you have for Dr. Bellan today. All right. Are you ready for these?
I'll try it all.
I'm sure you are. I'm sure you know all the answers. What are some common heart artery procedures, Dr. Bellan?
Well, the most common procedure is a diagnostic angiogram. You will hear people refer to having a heart catheterization, a heart cath.
Mm-hmm.
Coronary angiography is the medical term. This is injection of iodine contrast into the artery supplying the heart muscle. It is basically a movie of blood flow through the artery,
Okay.
which shows us where narrowings are. And following that, if a mechanical repair for a blocked artery is indicated, the patient may be referred to open heart surgery, to heart bypass surgery, or may have a intervention done through the catheter.
Okay. And what's the difference between a bare metal stent and a drug-eluting stent?
Well, a stent is a metal scaffolding basically in the shape of a tube, which is used to prop open a narrowed artery. Mm-hmm. The original interventional procedure, which was first performed around 1980, was the use of a balloon to stretch open a narrowed artery. And this was often very effective, but the problems you could have with that, one was the elastic tissues in the wall of the blood vessel would recoil. Early recoil was the medical term, and the narrowing would to some substantial degree come back. Or you could have a disruption in the lining of the blood vessel that restricted blood flow, and a stent props open the area, prevents recoil, and prevents obstruction from any tear or disruption in the lining of the blood vessel, and overall makes the procedure much more likely to be a good fix long term. Mm-hmm. In the intermediate term, scar tissue forming within the stent, restenosis is the medical term, may cause the narrowing to come back within usually 6 to 9 months. Generally somewhere between 9 and 12 months after a stent procedure. If you've made it that far without recurrence of problems, the results are stable. The drug coating on the stent reduces the probability of having restenosis. So you take a situation where you might have 20 to 30% chance of restenosis and reduce it to 10% or less.
Okay. All right. Next question. Are there procedures to avoid me having to have surgery?
Well, a stent procedure is minimally invasive.
Mm-hmm.
We will send people home sometimes within 6 to 10 hours after the procedure.
Wow, that's short.
But very often the next day. They'll
Mm-hmm.
stay in for observation overnight. It's rare to stay beyond 18 hours after the procedure. So that is a good choice if the anatomy of the arteries favors that approach. Mm-hmm. Stents are, as I mentioned, in the shape of a tube. If you have a narrowing of an artery in a straight segment of the artery, the stent is very reliable. When you have branches or bifurcations, bifurcation is the medical term for a branch point in the vessel, that is one of the situations where using a balloon or stent becomes more complex. And if you have large vessels affecting large amounts of the heart muscle involving bifurcations, we become more likely to recommend going to open heart surgery.
Mm-hmm.
Open heart surgery is a much bigger deal in terms of recovery time, time off from work. It takes a couple months to get back, but to full speed. But the bypass surgery is capable of addressing much more complex patterns of disease. And preventing needing any of that is risk factor management.
Okay.
Cigarette smoking, diabetes, high blood pressure, cholesterol.
Of course. All right. We have a question from someone watching on Facebook. Brenda Howington asked, what is aortic stenosis and what are the signs?
So the aortic valve is the valve between the main pumping chamber of the heart and the aorta. Every blood vessel in the body except the aorta pretty much is doubled. You have an artery to each arm, to each leg, to each kidney. The aorta is the main pipeline that takes blood from the heart to all the branches. Stenosis of the aortic valve is a common condition in aging. It's something we see fairly frequently in people in their 70s and 80s, sometimes younger than that. The narrowing will not cause symptoms in the mild to moderate stages, and the only sign at that point is a heart murmur.
Okay.
When you listen to the chest with a stethoscope, you hear the hissing sound of the blood flowing through the narrowed area. When the narrowing becomes severe, the overload of the heart muscle becomes significant. The pressure inside the heart may have to be 200 or above to squeeze the blood through the narrowing in sufficient quantities to feed the body. And at that point, replacement of the valve in some form becomes necessary.
Okay. All right. Thank you for your question, Brenda. Back to our questions from the Ask the Experts page. What is thrombolytic therapy?
So a thrombolytic is a clot dissolving medication. People will often be on lesser forms of blood thinning. They will take Coumadin or warfarin, which delays clotting of the blood and allows natural processes in the body to dissolve blood clots that have formed. But a thrombolytic will rapidly dissolve blood clot that has formed recently. The way that a heart attack happens generally is from blood clot forming in the coronary arteries and suddenly blocking blood flow to the heart muscle. In the 1980s, there were very large trials where the process of basically drawing names out of a hat and taking tens of thousands of people and giving half of them the treatment and half what was standard therapy at the time. And it was proven that people stay alive and healthy longer if you give the clot-busting medicine to restore blood flow to the heart muscle and minimize heart muscle damage. This was mostly in the mid-80s that these trials took place. And then over the next 20 years, it was shown that going to an emergency heart catheterization, where we use usually stents, as we discussed, or balloon procedures through the catheter to open the artery, we showed that this was better than using the clot-busting medications. Right now in Mississippi, things are very well developed for hospitals that do not have catheterization facilities to rapidly transfer patients to locations where intervention can be performed quickly.
Okay.
But it's very important historically in cardiology in rural areas where rapid transfer is not available. It can still be used to interrupt or stop a heart attack, and it is very important now primarily in the treatment of stroke. The same statewide system which focuses on getting people transferred rapidly if they are in the midst of having a heart attack so that they can have a balloon or stent procedure to restore blood flow, has a sister component where people who come in, patients who come in with a stroke that has started recently will very rapidly be given a thrombolytic agent to reverse the effects of the stroke.
Okay. So you may have answered, I think, the next question. It is, when is thrombolytic therapy administered?
Yeah.
Is there more to that? Or
Well, that's pretty much it, I guess. For cardiology, historically important and still in rural areas with delayed transfer, state-of-the-art for treatment of stroke. And the third category, I guess, that is important is pulmonary embolism. People may be familiar with stories of a completely healthy person who goes on a long car ride without stopping, or gets on an international flight where they're on the plane for 10 hours sitting in one position and then gets up and collapses. Forming blood clots in the veins of the leg predisposes you to have pulmonary embolism, where the clot travels from the leg vein to the lungs and blocks blood flow through the lungs. If the clot is large enough that it impedes the global circulation of blood and compromises blood flow to the whole body, thrombolytics will be used in that situation.
okay. I'm going to take a few more questions from our Facebook viewers. Liz Holland would like to know, she says, with a genetic history of sudden and hypertrophic cardiomyopathy, what do you do besides beta blockers? My brother has passed and my son and mother, but I have an IUD. Just what is the treatment?
Okay. So the genetic analysis of hypertrophic cardiomyopathy has advanced tremendously in the last 25 years. If I'm understanding the question correctly, if you have both the finding of hypertrophy is the term for thickening or enlargement of the muscle.
Okay.
An ultrasound of the heart demonstrates the structure of the heart, whether the heart muscle is thickened. If you have people who have died suddenly and unexpectedly in your family, and you have hypertrophy, then, as mentioned, beta blockers, medications which decrease the force of the heart contraction and the rate of the heartbeat, are also very effective in suppressing abnormal heart rhythms, but they're not 100%. The implantable defibrillator, the ICD, is further protection, and having an evaluation at an expert center where the genetic analysis is available is very helpful in a situation where you know you're at high risk because of family history.
Okay. All right. Thank you for your question, Liz. I hope you got your answer. Latasha Nicole Carter has two questions. The first one is, my father suffered from a heart attack last year and was placed on at least 3 different blood thinners and baby aspirin. How many blood thinners should one be on to keep a healthy heart?
So, with stent procedures, as we discussed earlier, the standard is to be on 2 blood thinners, a baby aspirin plus an additional agent. Clopidogrel or Plavix was the original medication in this class. that was advertised on television by the Denver football coach a decade ago or more, and is now generic. Effient and Brilinta are the improved versions, which are still used as brand name formulations. But a combination of aspirin plus a second medication is standard for an absolute minimum of a few weeks, and preferably for a year. Beyond that, you are striking a balance between risk, not specifically of the stent having a problem, but of any of your blood vessels forming a clot in a different location within the heart or in the brain circulation and having a stroke. There are large trials showing that in someone who has had a heart attack or had unstable heart symptoms requiring a stent procedure, taking Plavix or clopidogrel does improve your chances to a small degree compared to taking aspirin. So it's a very individualized decision for the patient. When you're on a stronger blood thinner, there are risks of bleeding.
Okay.
Strokes and heart attacks, brain cells and heart muscle cells do not grow back. In the worst case, with a bleeding problem, we can generally use a transfusion.
Okay.
So it's an individual decision. If we're talking about more than one blood thinner, sometimes abnormal heart rhythms, atrial fibrillation, will coexist with coronary disease, and in that situation you will often end up on a third blood thinner because the process of blood clotting is different in slow blood flow situations. The DVT, the blood clot in the vein of the leg that we referred to earlier, and the clots which cause strokes in people who have atrial fibrillation share that process of coming from slow blood flow, and medicines which inhibit the protein factors in the blood causing clotting are important there. And so when you combine aspirin and a second antiplatelet agent, the clopidogrel Plavix class of medicine, with an anticoagulant, a protein factor inhibitor commonly used for atrial fibrillation, the cumulative risk of bleeding does increase, but the blood thinners are not interchangeable. It's a difficult situation, and you often balance being on 3 blood thinners for a little while and then scaling back to 2 within weeks to months.
Okay. And so you may have answered her next question as well. Latasha asked, how many blood thinners should one be on after suffering a heart attack?
Yes.
And then it's funny that she was asking about that, because our next question from the Ask the Experts page was, what determines how long you will have to stay on blood thinners?
So we mentioned the restenosis process with stents. The drug-coated stents are less likely to have the scar tissue form and cause excessive narrowing within the stent. But the stent is a foreign material, and having the body reform some lining within the stent is favorable. So we don't have the means to dial up having a few layers of cells grow over the stent material and then stop. With the drug coating, the delay of ingrowth of tissue into the stent may leave the stent exposed to the circulation for longer, and in that situation, when a drug stent is used, the current guidelines recommend taking dual therapy, clopidogrel or Plavix class medicine plus aspirin, for a year. With plain metal stents, that can be shortened with considerable safety, relative safety, but at some increased risk of having the scar tissue form within the stent
Okay.
because of the lack of the drug coating.
Hmm.
So absolute minimum double therapy for 2 to 4 weeks and a year beyond that with a drug stent.
Okay. All right. You've got a lot of people watching and recognizing you. LaJohan says, hey, Dr. Bellan from Pod C.
Hello.
And also Nana James says, that's my doctor. Hello, Dr. Bellan. Karen Tripp says, I was on lisinopril HCTZ for 6 years. My doctor recently changed my blood pressure meds to Cozar. She had noticed with the lisinopril there were signs of early kidney damage. Okay. Hey, Karen, how are you? I know her.
Okay. I am not a kidney expert. Losartan and lisinopril are closely related. They both inhibit the angiotensin system, which tends to raise blood pressure. So both medications lower blood pressure. They are particularly favorable for anyone who has any weakening of the heart, and they are favorable for protection of renal function. The literature, as far as I know, does not definitively favor one or the other for protection of the kidneys, but either lisinopril or losartan is commonly used in people, particularly those who have diabetes, to protect the kidney function long term.
Okay. So that's actually a prescription for the kidneys.
We often have situations where medicines are given for multiple reasons. Someone who has some degree of renal insufficiency with no high blood pressure at all will still be put, if their blood pressure allows it, on a low dose of lisinopril or losartan or medications of that class.
Okay.
Because particularly in people with diabetes, it is proven to slow the progression of renal disease.
Okay.
But it's much more common that the factors which commonly cause renal disease, including high blood pressure and diabetes, those traveling together, you usually do want to lower blood pressure as well.
Okay. All right. Next, let's see. We've got a lot coming in, so I'm going to take a few before they get out of control over here, and then we'll get back to the questions from the Ask the Experts page. We have next, that's someone tagging, please talk and inform about HCM. What acronym is that?
I believe that's the hypertrophic cardiomyopathy. There was a specific question from the lady who had family members who had died suddenly, had an implantable defibrillator. So hypertrophic state refers to overgrowth of the heart muscle, excessive thickening of the heart muscle. And as I mentioned before, the genetics of that have been studied, and there's probably many dozens or hundreds of minor genetic variations identified which will cause the heart muscle to thicken excessively. A person with normal genetics, except for high blood pressure, who has extreme high blood pressure for a long period of time, will have thickening of the heart muscle, which can be substantial. So you can have what we call hypertrophic physiology, where the heart muscle has thickened in response to high blood pressure without any particular genetic predisposition. And by controlling the blood pressure, that excessive thickening will gradually reverse. Then you also have people who have the genetic predisposition, and even with a normal blood pressure will have extreme thickening of the heart muscle. Because when the heart muscle thickens in that, from either of those mechanisms, the pressure required to fill the heart can only pump out the blood that it feels when it relaxes. So the filling pressure, which spills back into the lungs basically, has to be higher to stretch the stiffened, hypertrophied heart open, and that causes symptoms of breathlessness.
Okay.
Can cause heart failure where you have fluid in the lungs, and can even cause a medical emergency in the extreme situation.
Okay.
So this is something we commonly analyze. The ultrasound of the heart, the echocardiogram, shows us the extent of thickening of the heart muscle, and if it is a mild to moderate degree consistent with what we know of the patient's history of having high blood pressure, you treat the blood pressure and monitor it, and don't go spending lots of money on genetic analysis.
Okay.
On the other hand, if you have a family history of people having seemed to be healthy and dying suddenly associated with hypertrophy, then you analyze much more thoroughly.
Okay, good to know. All right, Lawana asked, is it dangerous to take some, I'm going to read the
Yes.
names of these medications as best I can. I'm not
Okay.
familiar with them, so you see if you can get what I'm saying. Is it dangerous to take someone off Coumadin after 20 years and put them on Eliquis, not for heart problems, history of blood clots?
Okay.
Did I get those right?
I believe so. Clonidine, CO.
Looks like Coumadin or
Coumadin.
Coumadin.
I'm sorry, Coumadin. Yes, yes.
Coumadin. Okay.
So, Eliquis, Coumadin is the brand name of warfarin. Warfarin was funded originally by the University of Wisconsin Alumni Research Foundation. That's how I got the name warfarin.
Huh.
That's some trivia that nobody at all cares about. But it's been around for many decades. There have been, and it was the only option available pretty much for people who had atrial fibrillation or people, those low flow states that I referred to earlier where you have blood clot form in the vein of the leg, or you have atrial fibrillation which predisposes you to stroke.
Okay.
Now we have Eliquis and Xarelto and Pradaxa, which have come on the market in the last 10 to 12 years, maybe 15 years. I'm losing track of exactly when those came on the market, but they've been out a good while, but we've had a lot of experience with them in the what they call aftermarket phase. There's large trials that are done before a drug is released to be sold and prescribed, but consistently for atrial fibrillation and for DVT and pulmonary embolism, blood clot in the leg, the newer agents are superior. They have equal or lower bleeding risk and are more effective in doing what the purpose is, preventing events from clot formation.
Okay.
Warfarin or Coumadin has a very narrow window for the therapeutic effect, and the patient has to go in and have blood thinner levels checked frequently, and the dose adjusted. The newer agents are all much more consistent in their effect. You have to have your kidney function monitored because all of them to different degrees are cleared through the system from the body, partially at least by the function of the kidneys. But once you know the kidney function usually is stable month to month and usually year to year, but it should be checked once a year when you're on these medicines. But basically you're trading a blood test at least once a month and sometimes every week if you get out of range with warfarin, with checking the kidney function once a year on these newer agents, once or twice a year, let's say, depending on the individual. So they are an improvement.
All right. Good. Let's see. Lawana had a second question. She said they don't check PT, and it says
yes.
PTT as often. Isn't
Yes.
that risky? My family doc did it.
Yes. So, and your family doctor seems to be on top of things, as we've been talking about, as long as you know the kidney function. And I think at least once a year that should be monitored. That's part of a routine physical for most people, to have blood drawn once a year when they see their doctor. Assuming the kidney function is normal, that is one of the huge advantages of these medicines, is that the treatment effect is steady without having to individualize the dose.
Okay. Let's see. Lisa asks, does lisinopril affect your potassium? I hate AFib, she says.
Well, lisinopril does tend in some people to make potassium levels rise. If the kidney function is normal, that is rarely a problem. In people who have started to develop kidney disease, as we mentioned earlier, lisinopril is one of the medicines which helps protect the kidney function and slows the progression, so can often help keep people from getting to the point where you need dialysis. But the risk of building up excessive levels of potassium goes up if you have renal insufficiency. So if your kidney function is normal, worrying about potassium with lisinopril is very rare. But again, you should have your checkups and blood drawn once a year. If you have renal insufficiency, then it needs to be monitored more closely.
Okay. Thanks for your question, Lisa. Let's see. Karen Hansen says, after a stent was put in and all was great, how could cardiac arrest happen and they don't make it?
Well, I'm sorry if that's not just a theoretical question for you. It certainly does happen without knowing, even when we do know a lot of details of an individual patient. Without an autopsy, it's speculation, but there's, if you've had a heart attack, you are at some increased risk of having sudden abnormal heart rhythms. And so the artery that blocked to cause the heart attack has been opened back up with a stent. There's still been damage to the heart muscle, and we can't completely eliminate the risk of a sudden fatal abnormal heart rhythm. That's a very rare occurrence in people who have been screened for it, treated properly. We have mentioned beta blockers at some point in this. These metoprolol, atenolol, carvedilol are the common beta blockers. It is standard for anyone who's had a heart attack generally to be on one of those medicines, unless their blood pressure or heart rate is too slow to allow it. And those decrease the probability of having abnormal heart rhythms, ventricular tachycardia, but can eliminate it completely. And with stents, there is some remote risk of blood clot forming within the stent, even with the medicines. Taking the medicines properly reduces that risk to in the range of a chance or two in 1,000 of the stents suddenly acting up again. But that risk cannot be completely eliminated.
Okay. All right, Dr. Bellan, we're almost out of time, but we have quite a few more questions to get to, so we'll try to get to as many of you as we can, and we'll save the rest for the next episode with Baptist Heart. Let's see. Is the heart muscle in the heart wall, even are they the same?
Yes, so the heart, the purpose of the heart is to pump blood to the body. We've talked about stents in the arteries and bypass surgery. The heart muscle is in the main pumping chamber, the left ventricle, somewhere in the range of about 1/3 of an inch thick. The coronary arteries carry blood into that muscle to feed the muscle. And we classify the heart anatomy into walls based on anatomic orientation. Anterior is the front wall.
Okay.
Inferior is the lower wall that lays against the belly. Lateral out to the left side. Septum between the chambers of the heart. So, to answer the question, yes, I believe when you talk about walls of the heart, that is the heart muscle itself, the different segments of the heart muscle.
Okay. Rosie Boatner asks, what is regurgitation of the heart and does it cause shortness of breath?
We had a question earlier about aortic stenosis. Stenosis is the medical term for narrowing of a valve. Regurgitation is the medical term for a leaking of a valve. As with the aortic stenosis, symptoms are generally only associated with severe degrees of valvular dysfunction. If you have regurgitation of the aortic valve through which blood leaves the heart, the main pumping chamber of the heart, the left ventricle, or the mitral valve, the entry valve to the main pumping chamber, either of those regurgitant conditions, when they are severe, will cause symptoms and in general should be repaired surgically. However, our ultrasound technology is so good that we can see mild degrees of leakage in these valves in people who really don't have any problem from it. We will sometimes monitor them because some small fraction of situations where there is a mild degree of valve disease, the disease will progress, but sometimes it stays the same and never causes the patient's symptoms. So yes, valvular regurgitation needs to be analyzed in the context of the echocardiogram, echo findings, and I mentioned practicing general cardiology as well as interventional cardiology. That's a big part of what we do, is see people who have valve disease and assess what the probability of their particular valve lesion progressing to the stage of causing symptoms is.
Okay. Tell me if there's a quick answer for this one.
All right, I'll try for a quick answer.
What causes palpitations and are they serious?
That's a tough one to answer quickly.
Uh-oh, oh no.
Palpitation is the medical term for awareness of the heartbeat.
Mm-hmm.
The heartbeat seems irregular in some form. Anyone who's ever watched a scary movie has had the experience of when the scary stuff happens,
a lot are coming up next
the heart
month.
starts pounding.
Mm-hmm.
And if you become aware of that, that's a form of palpitation. Palpitation associated with loss of consciousness or near loss of consciousness is serious until proven otherwise. Okay, so
that same feeling of a scary movie.
Yes, the term applies to any awareness of the heartbeat. On the other hand, if you have a situation where you're, for no provocation that you can identify, the heart is suddenly running very fast and then it stops again, that can be some intrinsic short circuit in the wiring of the heart, and that should be investigated. The most common serious symptom with abnormal heart rhythms, not the most common, but the most dangerous symptom with abnormal heart rhythms is association with fainting or near fainting.
Okay.
It's kind of short.
Kind of. I mean, yeah, pretty good there. If we did not get to your question today, I apologize. We are just about out of time. The number's on the screen for Baptist Heart as well as their website. You could go there for your answer, or we will save it for the next episode. But Dr. Bellan, the cardiologists are going to get a break, at least for October. We are going to have the good doctors of Baptist Cancer Center on for the month of October. Baptist is a sponsor of our Power of Pink program. So we're going to pink out the hub. Our logo is going to turn pink. When you guys come on, we're going to have pink balloons and all kind of good things, because awareness is very important, but so is education. So we're glad to have the doctors from Baptist Cancer Center come on during the month of October. Thank you so much for coming here today. Thank you all for watching and for your questions. This is WLBT's Ask the Experts.